Good evening, everyone, and welcome to tonight's CPD webinar, Navigating MyMedicare and Preparing for the Aged Care Incentive. My name is Brendan Goodger, General Manager for Primary Care Improvement here at Central and Eastern Sydney PHN. Tonight I'm joined by Jane Sadler, Manager of Practice Support and Development, and our speaker for this evening, Wendy Amera. I would like to start tonight by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community, and pay respects to elders past, present and emerging. I would also like to extend that respect to any Aboriginal colleagues who may be joining us tonight.
Thank you so much, Brendan, and welcome everyone. Thank you for joining us tonight. I'll just bring my presentation up. So tonight's presentation, I'm just going to pop onto slideshow. Tonight's presentation is on MyMedicare and how we are and what we need to know to prepare our businesses for the upcoming incentives. So thank you again for joining me. I would also like to acknowledge the traditional owners of the land on which we met virtually tonight, and of course to pay my respects to elders past and present, and also to extend that acknowledgement and respect to any of our First Nations people here today. So let's get started. We've got a lot to cover. So basically at the end of tonight's presentation, you should be able to identify the components of MyMedicare and what it means to general practice, including what's been introduced to date. Describe the changes that are coming in 2024, particularly around the residential aged care home residents or the general practice aged care incentive, along with some changes we're expecting in our chronic disease funding models. We're also going to look at the need for practice discussion around the planning and preparation for what's coming and the determination and assignment of roles and responsibilities for the future changes. And finally, you should be able to recall where you can find some resources that will assist you in the preparation and the upcoming changes. So lots to get through, so we'll just move on and get started. So we'll give you a brief recap of what MyMedicare is. We are all aware, it's been around long enough now for us to know what it is basically. But basically, for those who have been or who are unaware of it, it is a voluntary patient registration program aimed at formalising the relationship between patients, their general practice, their GP, and the primary care team. It's been introduced as part of the recommendations from the Strengthening Medicare Task Force, which were published in December 2022, and it is part of a 10-year plan. So we have a 10-year plan. We're about 2 years into it now on how we're going to improve life in general practice. So I'm really excited about what's coming and what we've got so far, and I hope that you are also embracing the changes that are coming. There are going to be multiple incentives rolled out over the next 12 months, with future incentives also to include things like mental health and the first 2,000 days of life. At what context, we are unaware yet, but I do believe the first 2,000 days will bring back the introduction of those 4-year-old health checks and more services around that first 2,000 days, particularly for children and for their parents. So that's something exciting to look out for in the future. So what do we know so far? The Strengthening Medicare Task Force has an aim, it has a focus. What its goal is to improve patient access to general practice, including after hours. So we have seen the introduction of the urgent care centres and more staff being put into areas. They want to also improve patient access to a GP-led multidisciplinary care team, including our nursing and allied health. So as we know, there's a big push to recruit both of those services to general practice, along with the implementation of the significant increase in the nurse practitioner item numbers that we've seen that are coming up, which is going to certainly embed nurse practitioners into general practice as a feasible model. We're going to look at making primary care more affordable. So allowing patients access to care when they need it without the constraints or the fears of not being able to afford it, improving prevention and management of ongoing and chronic conditions, and of course reducing the pressure on hospitals. We know the crisis point our hospitals are at, particularly our public system. So this 10-year plan is aimed at trying to alleviate that by sending more funding back into general practice to allow us to provide more services to reduce hospital admissions. So that is a link to the Strengthening Medicare Task Force report. I found it really informative. So if you've got some spare time, I certainly recommend giving it a quick read. The MyMedicare timeline has shifted a little bit. So 1st of July last year, our practices were able to register for MyMedicare, including registering through PRODA. Then October, patients were invited to start registering either through their Medicare app or by completing a form that we were then able to assist them with the registration. In November 2023, we saw the introduction of longer consultation item numbers, the introduction of the Level E consultation, which is the 1 hour plus, and of course the triple bulk billing incentive, which has certainly been a game changer for a lot of practices who are struggling, who were solely bulk billing. So it's been really great up till now. As of the 1st of July, which is just around the corner, so this incentive is basically focused on 2024-2025, and it is designed, frequent hospital user incentive will be designed to provide wraparound care to patients who do not have a general practice, and PHNs will be involved, and I'll explain that off for you in a moment. And as we know also, as of the 1st of July, practices are now able to register for the GPACI or the General Practice Aged Care Incentive, which will come into effect on the 1st of August. And that is a large focus on tonight's presentation because that is something that is coming. We've got some information to share, so helping you to prepare your practices for that incentive is really important. And then, of course, we do have some changes coming around chronic disease management in November, which we'll also talk about. So lots to talk about, and let's get started with the benefits. So I find I get a lot of feedback from practice managers, GPs. How can we encourage people to register? Because a lot of people, there is actually no incentive. So someone who is well, not in any age group that's relevant, doesn't have a chronic disease, isn't eligible for the bulk billing incentive or the tripling of the bulk billing incentive, doesn't attend hospital very often, or doesn't live in an aged care home. They're saying, why? Why should I bother? What's in it? What's the reason I should join? So I'll share with you what we tell our patients. Yes, there may not be incentives available for you currently. However, we don't know what the future holds. And with the commitment from the government to improve our health services in general practice, particularly around mental health coming in the future, there may not be something for you now, but there certainly may be in the future. So when we talk to patients, what are the benefits to them? Obviously, a greater continuity of care with their registered practice, improving health outcomes. So this is about that commitment or that, that co-payment or that co-signing, that co-piloting agreement that, yes, I belong to this practice, you are my chosen practice and you are my chosen GP. This also helps when patients are admitted to hospital, for example, and there are discharge summaries that the hospital doesn't know where to send, so it doesn't get sent at all. With the alignment of patients to practices, that information is going to be more readily available, ensuring that there is more continuity of care through better feedback. Longer MBS items, obviously, as I said, not all patients will be eligible for some of these, but for patients who do require longer consultations, they are able to access this via phone, which will be fantastic, telehealth or telephone, versus a patient who's not registered will only be able to access the standard level B. More regular visits with their GP, so a more planned and focused plan for care. and also looking at the patients in residential aged care homes and how we can support them better. And that's
Mandy, just do you think you could speak slightly closer to the mic, just as long as we just want to make sure that everyone can hear you, right?
can you hear, is that better?
Yes, much better.
Sorry about that.
You're right.
So
Thank you.
thank you, Brendan. Apologies if anyone wasn't able to hear what I've said. So come the 1st of August, as we've already mentioned, the implementation of the program that will encourage general practices to attend and provide care for patients or residents living in aged care homes. And of course, the connection to more appropriate services in general practice for people who frequently visit hospital. So that's what we're going to cover off today. So that's what's available tonight. As a general practice, what are the benefits to us? MyMedicare practice can access more information about regular patients, making it easy to tailor the services to fit the patient's needs. This is particularly relevant around chronic disease, where a patient may be sharing their chronic disease services through other practices. So by the encouragement of the signing on to our practice, it ensures that we are the one who is managing their chronic disease, which is so important. As I said, the new longer telehealth items linked to MyMedicare, which allow us to access longer services for our patients. Level C and D with their usual general practice. The triple bulk billing incentive for your level C, D, and E. So obviously it is not available to anything less than 6 minutes. And for children under 16, pensioners and concession card holders. Just some facts or some points of interest. A patient can withdraw their registration at any time. So if they decide, no, I'm moving, or I'm not happy with the service, or I've changed my mind, they are able to withdraw it at any time relatively easily. We can assist by actually unregistering them through Proda. They can change their choice of provider. This is particularly relevant if a patient signs on with one of your registrars or a GP who then proceeds to leave the clinic for whatever reason. The patient is notified that the GP of your choice is no longer available and you will need to select a new one. So I actually received a text message from MyGov when my GP that I registered with, who was a registrar, left our business, and I was notified that he is no longer available and I'd need to log in and choose another provider. So that was really good. I found that really beneficial. There must be an existing relationship. So to be eligible to register for MyMedicare, the patient must have had at least 2 visits to your practice in the previous 24 months. So if you have a new patient attending today, you can register them or complete the form, but you cannot register that patient until they have completed 2 visits. However, it is only 1 visit or 1 visit in 24 months if the clinic is located in MM6 or 7. So not relevant to your catchment, but something worth knowing that if the patients live in those more rural or remote areas, there is only a 1 visit to qualify for the existing relationship. Patients can still access care anywhere. That's really important, that they understand that, yes, you are signed on to our practice or you are a part of our practice now, but if you need to attend another service, you are more than able to. It's not going to restrict what services you can attract or what you can visit. If a provider who is registered with a patient, so one of your GPs decides to either move to a new practice or move interstate, the patient can follow this GP without having to re-establish that pre-existing relationship. So a good example of that would be a GP who is working with your organisation and moves to an organisation within your area, so still accessible for patients. The patients can follow that GP. They will need to re-register with the GP at the new service, but they will not have to meet the 2 visits in 24 months. They will automatically be covered off under the existing relationship that they already have with the GP. So that's something worth knowing. So what's next? So let me briefly touch on the frequent hospital use incentive for something. There's not a lot of information about this, so I can only give you what's been available to us up till date. But what it is from the 1st of July, which is coming up very quickly, this is an incentive that will be starting in July, but we'll be looking at the 2024, 2025 calendar year. So they're probably going to see more movements around that, perhaps a little bit later in the year. What is it? It's a wraparound primary care for frequent hospital use. So it's designed to identify patients who regularly attend ED departments for services because they do not have a nominated GP. So they are attending ED versus attending a service which could quite easily see them, and it's therefore increasing the pressure on the ED department. So what they're looking at is how can we reduce the pressure so that ED is dealing with emergencies and general practice is dealing with these presentations that could very easily be managed within their environment. So from so Basic Services Australia will get around $16 million, which will run through to the 27-28 financial year to reduce unplanned hospital attendance for patients who meet both the following: have a complex or chronic condition and frequently present at hospital. They say to be a frequent flyer, it needs to be around 10 presentations a year. The incentive that is going to be made available to general practices is around agreement to register that patient with your organisation and take on their care. So basically the new incentive patients will agree to register their complex needs, which are identified by a public hospital in collaboration with the PHNs and a primary health. So they're basically identifying repeat presenters, working with the public hospital and the PHNs to identify and direct these patients to a general practice. What does that mean for us? First of all, the practice that they are directed to must be registered with MyMedicare to be eligible to participate. The patients will be connected to an identified practice and providers through MyMedicare. They'll get regular, comprehensive, multidisciplinary, wraparound primary care tailored to their needs. And I think that's the key point, isn't it? When we're looking at any kind of patient care for complex needs, it's about that wraparound, individualised care. How are they going to be identified? So basically the government will work with the public hospitals, and the PHNs will work together to provide payments to practices in addition to the MBS subsidies available for whatever item numbers are generated. It's going to encourage the comprehensive care. At this stage, there will only be 9 primary health networks selected or invited to participate. To date, I don't know of anyone who's actually aware whether they are invited or not. So your PHN may not be one of the first PHNs to participate in this program. However, the first 9 will be invited to work with the system from 24-25, a further 9, 25, 26, with the remaining PHNs invited after the 1st of July 2026. So around that year, we will have all 31 PHNs involved in this program. What is it? It's a new blended funding payment that will support better care for patients frequently attending hospital. It's going to roll out progressively over the next 3 years with 9 PHNs being involved. The final details of funding are yet to be announced, but the information I have been able to gather is that there's going to be some type of tiered payment system over a 3-year period. It is unclear whether the payments will be made to the GP or to the practice, or a combination of both. The first year, there will be a payment of $2,000 per patient that is taken on as part of that incentive. The second year, there will be an additional payment of $1,500, and the third year, $1,000. So this is just information that's been glossed over in a lot of the health ministers' discussions. There is nothing I can actually direct you to put in writing for you. So this is just what we have been told through conferences and through webinars. There will also be a bonus for practices who maintain or reduce the number of hospital admissions that that patient is taking. So, for example, Wendy O'Meara goes to ED 10 times a year because I don't have a GP. Public hospital system identifies me and works with my local PHN in the area that I live with to engage a GP service to take on my care with my grants, of course. And if my hospital admissions reduce, the practice will receive those types of payments with that bonus if it gets below. I think there's actually no figure. I don't know that there's going to be, okay, if you reduce it by 5 visits, you get it. But there will be hopefully some more information coming out to us soon. Now, the general practice aged care incentive is a real focus on tonight because this is something that we have recently been given a bit more information on, and it's something that's so important to our community. So I'm very much a supporter of this program in any shape or form. So what is it? It's going to be introduced as of the 1st of August 2024. So payments will begin to be calculated in the first month of the next quarter. The General Practice in Aged Care Incentive, or GPACI, will support regular health assessments, care plans, and a more structured plan of visits for patients living in residential aged care homes. It will replace the current aged care access incentive that we are receiving, with the final payment for the aged care access incentive being made in August before the new payments are generated in September. It's a blended funding package that aims to support regular health assessments, care plans, and a more structured regular GP visit for some of our 200,000 plus aged care residents. To be eligible for the service or to receive the funding, practices must be registered with MyMedicare, and their residents must also be registered. At the moment, this is what we have. We have the Aged Care Access Incentive, which is basically a payment to us based on the number of services we provide, and it's tiered into 4 levels. So if you're not familiar with it, basically, if you provide up to 99 services in a 12-month period, you'll receive a payment as a SIP, or a service incentive payment, paid directly to the GP of $2,000. Then it is staggered upwards to a maximum of 180 services, where you will receive a total of $10,000. It is capped at 10,000, so all of those numbers add up to 10,000, and it is based wholly and solely on the number of services you provide, with a maximum incentive of 10,000. I apologise for that, the way that appeared. What's going to change? What is the new system? The new incentive will include a $300 per patient per year payment to the GP, paid quarterly. So broken down into 4. If you have 10 residents, your payment for the year will be $3,000. It'll be broken down into 4 quarters, so you'll receive $750 per quarter as a SIP, a service incentive payment, directly to the GP. However, on top of that, the practice will now receive $130 per patient registered as a PIP payment. So this is the first time that general practice, the actual practice, has been recognised for a payment for providing aged care services. And I think it's been in recognition that there's a lot of work that goes behind the scenes to encourage our GPs to visit the aged care facilities or homes. And it's trying to incentivise us as practice owners or practice managers to coordinate a better model of care for those residents. So a total of $430. If you, for example, are a solo practitioner who visits aged care homes, you'll receive the $300 for your patient and the $130 as well. So $430 per patient per year. If you're a GP employed by an organisation, you'll receive the $300 and your organisation will receive $130. Rural loadings will apply. So depending where you are located demographically, if you are currently receiving any type of loading in your PIP, that will also apply to your aged care access incentive payment. and the $10,000 cap has been removed. So basically the amount that you receive payments will not be capped. The funding also sits on top of our existing fee for service. So it's not instead of, it's as well as. So basically you will still be able to generate all of your aged care service item numbers. However, this funding or these payments will be on top of that. To be eligible to participate in this program, the practices will be able to register from 1st of July through MyMedicare for the general practice in aged care incentive. So I believe this will be very similar to the way we registered for MyMedicare. We'll go into PRODA and into our incentive section, and we will find the general practice in aged care incentive and we will select it. So quite simple. It will be a drop-down box. We will see the incentive there and we basically tick it and press submit and we will be registered. So it's really quite simple to do that on a practice level for the registration. And then we have to look also at ensuring that our providers are linked to our organisation. So ensuring that all of your GPs are actually linked to your organisation. So if you haven't done that, it's probably a good time to be just checking on that, particularly if you have been able to attract new GPs recently who may not have been added to your organisation as yet. The GP will be declared as the responsible provider. So there's going to be that ownership. So a GP will be nominated by the patient as their responsible provider, who will be the provider of eligible services to their patients, including the coordination of other services provided by the healthcare team. So what does that mean? The GP will also coordinate the visits by the nurses or the nurse practitioner or by allied health if you have any of those services engaged in your organisation. For the patient to be eligible, the patient must permanently live in an aged care home, not be in respite, register with MyMedicare and link to an eligible practice and provider, which would be your organisation and you as a GP if they are your patients. When the 1st of July rolls around, there will be an indicator available in the enrolment process through PRODA that will allow us to tick GPACI, or that the patient is residing in an aged care home, to identify these patients as being eligible for the payment. So that will be available also come the 1st of July. So at the moment, we register patients either through PRODA ourselves as a result of them completing a form, or we ask the patient to register. Now, I'm not sure whether we're going to get any questions about this, but I'm going to talk about it anyway. There has been a lot of questions raised about what about those residents who cannot sign for themselves. So those residents who may have dementia or other cognitive disorders, who do not have a next of kin, do not have a medical power of attorney, what are we going to do? How are we going to register these patients? So the question has been asked. There is no clear answer yet, but the question has certainly been raised, and I do believe they are looking at how that's going to work. We, for example, have one resident in our aged care facility who does not have anyone. She has no family, no carers, no medical power of attorney. She's not even under the state trustee. So that's a real conundrum for us, how we're going to actually register her for our services when she is unable to understand and sign for, to register. Patients can be registered by their practice from the 1st of July. So it is, the 20th of June. We've got 10 days to go. So we need to start preparing now. What are the requirements? As we know, whenever there is an incentive given to us, there is always requirements that we need to meet. The servicing requirements are quite clear. The GP or the practice must deliver 2 care planning items over a 12-month period. Now, that's not a lot, is it? And I will go into what those care planning item numbers are for you in a moment. And also provide 2 regular visits per quarter. So that's 1 a month, each in a separate calendar month. So they're saying basically to be eligible, you just have to provide a health assessment and a contribution to the residential aged care plan and see them once a month. So that's going to be really easy for the GPs who actively look after as residents in aged care home. And I'm really hoping it's going to encourage the other GPs who don't look after aged care residents to actually start to take place in this. We must deliver a total of at least 8 regular services in a 12-month period. So not a lot to ask, is it? Care planning, as I said, I find it strange that they call the health assessment or the CMA a care plan, because it's not, but that's where they have listed it as. So a CMA, as you know, is the aged care home equivalent of a health assessment, which we can conduct on a yearly basis. And there are the MBS item numbers available to us. And as you know, they are based on time spent with the patient, including the time your nurse spends. So if you are sending your practice nurse to do the interview with the patient, and then you're going back to just complete it with the resident, then you bill your time and the nurses as well. Contribution to or review of a multidisciplinary care plan. This is probably one of the most utilized item numbers available to us when we look at the aged care sector. An item 731 is basically the aged care home equivalent of an item 732. It is the review and contribution to the facility's care plan. As you know, when a resident is admitted or decides to move into the aged care home, an assessment is made and a care plan is written based on the care plan is based on the amount of funding that's received. So they have their own care plans. So when you go to the organisation and assist the facility by monitoring the patient and planned interventions around their care, you are contributing to the care plan. So this is an item you can bill every 3 months, and it's probably, as I said, and I'm sure there's exceptions, but most GPs either don't even know about it or just forget about it. So please keep it in mind, because it is something that you're doing anyway, and it's something that you can certainly be using to contribute to the requirements for your aged care access incentive. Brendan, did you want to say something?
Yes. Look, Wendy, I wonder if we could take a couple of questions. They're coming through, and
Sure.
I don't want people to wait, right? So,
yeah, okay.
Look, I think I could probably have a stab at this answer, but you might answer it with a bit more detail. Do you need to be an accredited practice to be eligible to receive the aged care incentive?
Yes.
Yep. So the answer to that is yes.
Yes.
Yep. Thank you for clarifying that.
And basically,
and the other question,
because it's a PIP payment, and registered patients practices who are not accredited do not receive PIP. However, they could be registered to start the accreditation process, so they could be beginning the accreditation process, then they can apply for it, but they must then achieve accreditation within 12 months.
So let me just paraphrase what you've just said. I think what you said is they've got to be an accredited practice. However, they can be registered. That lasts for 12 months. At the end of that, they have to be accredited. That's what I'm hearing.
Yes, so if a patient is engaging in the accreditation process, so they're preparing their practice for their first accreditation, they can register for the PIP, which then will then allow them to register for the MyMedicare incentive. However, they must achieve accreditation within 12 months of registering.
I think that's pretty clear. Now, just anticipating a further question, what happens if they don't achieve accreditation at the end of that 12 months?
Very good question. So the payments will then be ceased until accreditation is received.
All right, thank you.
And they won't be able to reapply.
Now, do you have to work at an accredited practice to receive the SIP and PIP payments under GPACI, GP and Aged Care Incentive?
That's a very good question, and we did talk about that. There's not, I would love to give you a definitive answer. There has been a lot of discussion around this in a lot of GPs who do not work in accredited practices, or do not work in a facility, are not linked to any organisation, but attend aged care residents as part of their care. I cannot answer that at this stage. However, I will certainly keep my ear to the ground, and when more information becomes available, and I'm sure the PHM will certainly be all over that as well. So unfortunately, there's no definitive answer. I hate to say one answer when it turns out that once things get put in place that it's not the right answer. So
I'll tell you what we might do. We might take this really good question from someone called Anonymous Attendee, and we will pose that to the department, all right, to the Commonwealth.
Good idea. Yes.
Now, the final question, if I can say, and then we'll get on with the presentation, is this one's got me a bit stumped. What item number for multidisciplinary care?
731.
What? Sorry, what was that?
731.
731. It
Yep.
almost sounds like a phone number, but 731. All right.
So 731 is the item number you would bill every 3 months to participate in the multidisciplinary care plan of an aged care home.
All right. That's all the questions for now, I think. But
thank you for questions, and we'll keep going. If anyone
yeah,
else
please
has any
do.
more, please.
And we'll come back. We'll come
Thank
back.
you.
All right.
Okay, so 731, it's around $79.30. It will increase on the 1st of July when our rebates increase. And I think it's going to be about $80.10 come the 1st of July. So definitely with the bulk billing incentive is definitely worth doing. And it's something you're doing anyway. I say that to my GPs all the time. You are providing the care. You are participating in the care plan. You're just not being remunerated for it, basically. And it can be billed with a 90035. So if you go to the aged care home and you bill your 90035, you can also bill a 731 at the same time, because you're providing a service that's independent of the review of the care plan. So that's something to keep in mind as well. Something I do is just a throw in. I found there's a lot of practices who are not aware of the 90005, which is the call out fee when you attend an aged care home to do a COVID vaccination. So all GPs are aware of the 90001, which is the call out fee we receive when we go to the aged care home for the first patient or first resident. But not many are aware of the 90005. So if you go to the aged care home and administer a COVID booster to any resident, the 90005 is around $126.90. So it's definitely worth remembering, and you can backdate for up to 12 months. So Medicare guidelines have changed. You used to be able to backdate services for 2 years. It has been reduced to 12 months now. So if you'd like to go back and have a look at what you've done recently, you can certainly still lodge a claim for that item number. So keep that in mind, because it's a great incentive to go to the aged care home which you're doing anyway. Now, with the GP multidisciplinary case conferences, again, something that we could do better. There are 2 types of case conferencing. There's a GP who coordinates or the GP who participates. And as you'll know, there are different item numbers around that. And that is something that aged care homes would be really happy to have implemented, because that whole multidisciplinary care basically relies on conversation. It relies on sharing of information. So case conferencing can be really valuable to your residents, and that is why I believe that the department has included case conferencing in part of the care planning item numbers. And of course the medication review, or the RMMR, or the item 903, which can be done 12 monthly. And just in case someone asks, yes, it can be done more frequently if there has been a considerable amount. I had a doctor ask me last week, can it be billed less than 12 monthly? The answer is yes, but there must be a significant change in the patient's medication. So medication review is completed today. A month later, the patient has a serious incident or develops a new condition that requires a whole series of new medications or a hospital admission, and all these new medications are implemented, then yes, you can certainly do it again. So keep that one in mind when you're looking after your residents. So quarterly visits, we must have at least one of these quarterly visits must be provided by the responsible GP. So remember, the GP who is the one whose name is on the MyMedicare form, they are the responsible provider of those 2 quarterly visits. Only one of them must be done by the regular GP. The second visit can be done or delivered by another member of the team. So another GP, could be a registrar, it could be your nurse practitioner, It could even be an Aboriginal health worker if that is relevant to your organisation. So one service by the registered GP or the responsible GP, and then another service can be provided on your behalf by someone else. If you are located in MM4 to 7, of the 8 yearly visits that we must do, 4 of those can be via telehealth. So this is obviously in recognition that the more rural or remote the aged care homes are, the less opportunities there is to visit them. So being able to provide 4 of those services by telehealth will certainly be a value to you. So there's probably a lot that's done by telephone anyway, but of the 8 services, only 4 will actually need to be face-to-face if you are in 4 to 7. So something that is worth knowing if you are located in any of those areas. Regular visits include your attendance as an aged care, so level B to E. Don't forget that E. Sometimes you're there for a long time. Don't remember there is still an E for all those residents. Any after-hours services that you provide, nurse practitioner services on behalf of your GP, practice nurse and AHW services, and the bulk. Don't forget the triple bulk billing incentive currently applies to most of the aged care items, and there is suggestion that there will be an increase in the triple bulk billing incentive for more item numbers in aged care homes to assist in the encouragement of service provision. Brendan.
Now, Wendy, congratulations, because you're getting an awful lot of questions.
That's good.
So we might take a few now. Is that all right?
Yep, absolutely.
Great. So look, a very esteemed GP, whom I know pretty well, has asked this question. What happens with patients admitted to aged care facilities for palliative care and who die within 12 months?
That's a very good question, and I have the same one myself. So thank you for bringing that up. What the big gap in the knowledge at the moment is, how are the payments going to be calculated as far as residents? So let's use an example. On the 1st of August 2024, your practice has, let's use a nice round figure of 20 residents. Okay, could be a lot more, could be a lot less. 20 residents. In the first quarter, so from August to November, 10 of those residents die and you get another 10 residents in their place. Does that mean you're going to get payments for 30 residents because you provided care to all of those residents in that quarter? Or are you only going to get payments for the residents who are currently registered as of the first date of the next quarter? I would love to answer that for you, but there is just no information at all. My GPs have the same question. We have 70 residents, and that the turnover, for want of a horrible word to describe it,
yep.
but the turnover is quite large. So one day there's 70, the next day there's 50, but the day after there's another 70. So how is that going to be calculated too? So to the esteemed GP that's asked that question, thank you. It is certainly something that I have recognised. I don't know if there is going
I'll tell you what we'll do. We'll take this question up,
yep.
and we'll also pose this question to the Commonwealth.
Yes.
We'll send it off tomorrow.
Yes.
Now, look, the next question, right? It's good we're getting these sort of questions because they're tough ones. So now, with regard to the need for 2 visits in the last 24 months, what happens with new patients in RACFs whom one hasn't seen before?
You have to wait till you send them twice. So what I recommend is to register them anyway. Get the paperwork completed when you're inducting the patient into your business. So when you go and do the admission and do all those bits and pieces, advise them that you would like them to sign up to your practice for you to provide that care. You will have to hold the form until you have seen that resident twice.
Now, thank you for that. Now, look, we've got quite a few GPs in our region who work exclusively in RACFs. They don't actually have a physical practice. Really, their practice is their car, or they would say out of their phone. How do they become accredited?
Very good question, Brendan. And I think that at the moment, the guidelines are quite clear. The practice must be accredited and the GP is registered with a practice. So there is no room, or they're not making allowances for exactly that. The GPs that actively participate in an aged care visit but are not located at a practice that is registered. So do those GPs belong anywhere, or are they just like a locum service that
They
just...
are literally a mobile GP service. I know them well.
Yep.
These are long-standing GPs, if I can use that word, who have dedicated a large part of their life to working in the area of aged care. They are mobile GPs, small, they're solo by themselves, work off their phone, and work out of their car, right?
Yep.
So how does GPACI apply to them then?
It doesn't, basically, unfortunately, because they are not eligible for GPACI because they are not registered with a practice. You know what? Let's pose that. I know that question's been asked in many webinars, and the answer was basically skirted around. But there is recognition of that group of providers, because it's not just in your area. There are a lot of areas within Australia where we have that type of service operating. But at this stage, if I were to answer you directly from the guidelines and what is being introduced so far, they are not eligible for the incentives because they are not with an organisation that is registered for MyMedicare.
Well, they're dealing with system, so I'll tell you what we'll do. We will take that question up again with the Commonwealth, and we'll also send the answers back to those people who have registered here tonight.
Yeah, and I think it's valuable to them to get that feedback, because the big picture hasn't been thought through. They haven't thought about these kind of services, have they? You know, what about those mobile services that provide great care?
Yeah, they do.
Where are they going to receive their payments? So can I ask the GPs that are involved in that organisation, do you receive a SIP currently?
Well, we'll see how many people respond to on the chat in relation to that. But can I just do the final question, then we'll continue on with the presentation. Is there an age limit on who can register on MyMedicare as a patient?
No, not at all.
All right. So the 103-year-old is welcome to register.
Absolutely,
right?
absolutely.
All right.
All right. So just to repose my question to those GPs, just for my influence, is: are you currently receiving the aged care access incentive? So that's tiered payment level. That we do. If someone could answer that, please. All right.
Yeah. So I just want to pick up on a comment, which is, someone's posted a comment in the chat, which I am deeply, deeply sympathetic to, which is around how the government is going to accommodate, those aged care providers, those who are exclusive to aged care providers. So again, to that GP who's posted that comment in the chat, we will come back to you. I promise you we'll come back to you. We'll try and prioritise this tomorrow and get an answer. All right. Wendy, I'll hand back to you for a bit.
Thank you, Brendan. All right. So that completes the section on the aged care access incentive anyway, but I'm, again, happy to take further questions at any time if they come up. The next change we're going to talk about is information around the changes made to chronic disease management, which again is a recommendation from the Strengthening Medicare Task Force and the MBS Task Force review, which is performed to look at the use of item numbers in general practice. With chronic disease management, from the 1st of November 2024, there will be a restructure. So basically, patients who are linked and registered with your practice, you will be the only person who can provide it. However, if they are not registered with you or anyone else, anyone can provide it. So it's not limiting them, it's just restricting other practices from charging it. What does that mean? If your patient is registered with your practice, you are the only practice that can provide chronic disease management. So the patient, and this is to stop those opportunistic billings where a patient may go away or see another practice because they couldn't get into your practice, and all of a sudden a care plan has been done on someone inappropriately. So there's been recognition that this is happening and has been happening for a long time. So they have, the ownership of saying, okay, this patient belongs to your organisation, so you're the only ones who can provide that appropriate ongoing care. However, as I said, if the patient chooses for whatever reason not to register, it is certainly not going to disadvantage them in any way. They will still be able to receive chronic disease management as they were before. It just will not be limited to just your practice. As I said, we'll hopefully reduce that opportunistic claiming, which does happen by many other practices. We've all seen it. Our patients come in for their regular review. The nurse spends a time, the doctor or the GP spends a lot of time finalising care plans and getting everything right, and then it gets rejected because it has been billed elsewhere by someone else, usually without the patients even knowing. So something that's going to be introduced to address that issue that we are having. There is also the intended removal of item 723. So the TenCare arrangement, as we currently know it, will be removed from the MBS as of the 1st of November. And the only requirements for a care plan is a 721. So a 721 will basically ensure eligibility for access to allied health services that are subsidised under the current program. With the removal of the 723 also comes the removal of the red tape around it. So you will no longer be required to wait for feedback from other providers before you can bill the 723. It is still going to be, I believe, best practice to share information. So continuing to share information shouldn't cease. It just means there'll be no delay in the billing because you won't have to. You are not required to now get consent to participate. And there will be a rebalancing of the 721 and 732. What does that mean? It basically means at the moment, the 721 is around $160 and the 732 is around $80. And that's ballpark. It's not that exact amount, but just for argument's sake. So you can see it's basically 50%. What they will do, without being able to give you the exact figures, they will reduce the rebate for the 721, but they will increase the rebate for the 732 to be of equal value. So it may be that they choose to reduce the 721 to $110 and increase the 732 to $110. I don't know the figures. Nothing has come out yet. I've been eagerly looking at the websites every day, looking for information, but this is all that's been made available at the moment. So there will be a reduction in the 721, a large increase in the 732. Why are they doing this? Because it is designed to do what we set out to do, and that's to regularly review our patients with chronic disease. So instead of, and it's not often at a fault of the GP, the patient comes in to see you in January and they want their care plans put in place because they want the allied health referral so they can access their subsidised rebates, usually at the request of allied health. So the podiatrist is a common one that will send all your patients back to you in January to get their new allied health referral. But what's happening is then the patient's not coming back for 12 months. So they're not coming back to have those regular reviews. And then they come back again the next year, and then another 721 and 723 are being performed, and the actual MBS requirements around the regular reviews, or at least that one review in a 6-month period, are not being met. So they've decided we might as well reduce it, and to be able to receive similar remuneration, you have to do your regular reviews. So if we look at numbers at the moment, if you bill a 721, 723, it's about $270. If they increase the 732 to around $100, and you do your 721 and then 3 reviews, you're going to get $400 per year. So it's going to be similar in rebate, but it's going to encourage GPs to actually perform those reviews. And it could be that you need to start getting a bit smarter with your patients and saying to them, I'm going to give you a referral to your allied health for 2 services, and you need to come back and see me in 3 months, and I'll give you another 2 services, and then once you come back for the last time, I'll give you the final one. So that is one sure way to get them back. So keep that in mind if you are having difficulty getting your patients to come back for their reviews, because there is going to be a considerable drop in the revenue around care planning or chronic disease management if we're not performing regular reviews. So now we know what's coming. How are we going to integrate it into our business? How are we going to get this process started? Because we are very quickly running out of time. So obviously the first thing is, if you haven't already done it, the first thing you must do is enroll your practice with MyMedicare in Proda, because all of the new incentives directly related to this. Educate your staff so that when your reception staff or your nursing staff or you as a GP is asked about it, you have the answers. You can explain it to the patient. The discussion should be had about the benefits, and the best person to discuss that or to convince patients that there's benefits to them is their GP. As a practice manager for a long time, I can assure you that GPs have the ability to convince patients something that I as a practice manager don't. If the GP says to do it, they'll do it. If I as a practice manager or one of my admin staff rings them, they're less likely to engage or commit. Ensure, as I said previously, that all of your providers are linked to your organisation. Patients will not be able to select a regular GP if they are not linked. So they're going to go onto their app and they're going to pick your organisation, and they're going to look for your name and you're not there. So they will not be able to find you if you are not linked through Proda. Start the conversation. Many of us started it early and then it's all fallen by the wayside because we just got busy with, the flu season and all the bits and pieces that are floating around general practice at the moment. We need to start that conversation, whether it be through your nursing staff, your front ends for your front office staff, or through yourself and your patients' engagement, and encourage enrolment. Offer transparency. So, say to the patient, by enrolling, it will allow the facility to perhaps, I say perhaps because, there's no guarantees there'll be any additional funding for those people that don't have any of the other conditions. It may provide us with additional funding, which will allow us to provide more services to you. So they'll be able to, it might not be relevant to you, but it will allow us to provide more services to your mum in the aged care home, or to your child. Or so keep that in mind, that transparency really is something patients appreciate. They respect the fact that you say, yes, I will be able to receive additional income or additional funding to help me provide better services to you, my patient. So I think that is a good way if you're having trouble with that. Links to MyMedicare registration on your website, so patients are all aware of it. There was to be a national campaign that was initially to be rolled out in February. It was then changed to July. It's now been pulled, and the department is basically saying GPs need to do this. So they are basically, there is going to be no big national awareness campaign on television, on the radio, which we were expecting. It's going to be more about the GP explaining to the patients. You could perhaps use a link on your online booking platform to the MyMedicare website. Handouts I find are really valuable, something really simple so that the average person can look at it quickly and has a really quick, clear step instructions on how to register. Have registration forms with your doctors. So my GPs have them in their room, and when the conversation starts, it's a reminder to have the conversation, and then the patient will come out with their completed form and we will register them on the GP's, on patient's behalf. Now, this is one we really need to get onto, isn't it? So this funding is going to start on the 1st of August. So it needs to be, all of your residents must be linked to your organisation by the 1st of August. So we haven't got long. So we need to really get onto this. And another way is to perhaps allow access, limited access to PRODA for your reception staff if they don't have it, to allow them to process enrollments and check availability or eligibility, I should say, because as you know, when someone goes to register, they will certainly look at those 2 visits in 24 months and their eligibility will be determined before you can register them. So your admin staff could assist in that process. What systems do you have in place to actually check who's registered for your, who's registered, who's enrolled in your practice? What systems, as a GP or as a practice manager, could you tell me how many patients to date you have registered? So we need to put systems in place to actually, to identify that the patients have enrolled and flag it in the software so that we know they're eligible for those longer consultation item numbers, for example. How are you identifying them? Are you just checking PRODA once a week, or you? How are you doing it? I'd love to hear, maybe at the end, how you're doing it. I can tell you how we're doing it. Software developers are working towards integrating into your practice management system. Now, Best Practice has already developed a way of bulk importing MyMedicare information. It's a script that they've written that you basically run. You extract your list from PRODA, you save it on your desktop, you run it through this tool, and it will basically identify in Best Practice with a big green tick, MyMedicare. And the GP will then know that that patient is currently registered for MyMedicare. Or you can manually enter the information demographic in the demographic section, and it will produce the same outcome. But that's very time cumbersome and it's not always kept up to date. So there is still further integration needed. I'm not aware whether any of the other software developers have actually released anything as yet. And there will be eventually a link in the My Health record, so we'll be able to access information that way as well. As with everything, data is the key. So by getting the information, pulling it all out so that we can see, we can start to plan. So now we know what's coming, how are we going to prepare for it? And as I said, leveraging data is definitely the answer. Patient eligibility should start now. So you need to look at particular cohorts and start to identify them, particularly around the changes to the chronic disease management. Ensure your practice is ready, but where do you start? Okay, I know I've got to leverage data, but what data? So let me help you. Basically, the first thing you need to do is make sure your data is cleansed so that you're not running inefficient data or inaccurate data. It's probably a better word. So do a data cleansing before you start the process. Archive any inactive patients, identify and remove any duplicate patients, and clean up any free text diagnosis to help you run more accurate reports. Use the recording usual GP is quite valuable. If there is an option in Best Practice, as you can probably tell, I use Best Practice, so I'm very familiar with it. But there is an option to record the usual GP within the patient demographic. Ensure your GPs are coding their consultations correctly, and particularly around aged care visits and chronic disease management. Use your software to run some reports. So look at things like patients who constantly require longer appointments. So, Cubico or PenCat or Polar is able to extract this information for you. And that will also identify usual GP by number of visits. Start to look at those patients with chronic disease that you would like to get registered to ensure that they are going to be a patient belonging to your practice and not at risk of someone else performing their chronic disease management, particularly those long-term patients. And you could run some reports even on the chronic disease management over the last 4 months and look at who is due for any 723s before we actually lose them. So it might be an opportunity to perhaps do a bit of a chase up on those patients and try to get them booked in early. And of course, our regular patients. Using that data to then target specific cohorts of patients. For example, as I said, the chronic disease patients or those in new age care homes. Decide how you're going to contact the patient. Are you going to just opportunistically speak to them? Are you going to send them a letter inviting them to enroll with your practice along with a form? Are you going to contact them via SMS? So have a look at, if you plan to have a targeted approach, how are you going to do that? You could send, as I said, a letter or the SMS with a link to the form, or you could give each GP a list of their patients and encourage them to have the conversation. So use your data, extract lists identifiable to a GP, and say to that GP, here's your list of current patients with chronic disease, or here are your lists of patients who are in aged care homes. How are we going to get these patients enrolled? And do you have a question, Brendan?
Yeah, well, I might make a comment, which is, we know that it won't necessarily just involve am I still there? Yep, sorry. We know that it won't just involve a conversation with the resident. It will typically involve conversation with a carer.
Possibly, absolutely. So if the patient is the one that must sign unless the patient is unable to. So absolutely, but the carer, I find, and I'll just use our organisation for example, our GPs are requested to take the care of the patients. The GPs liaise closely with the family and the carers. They build up a relationship with them. But yes, does that mean the aged care facility or the aged care home? No, they have no clue what it is. So you don't have to get their consent, but you certainly have to get the patients. And yes, involving the family's carer in what you are doing is always a valuable thing to do, even if it's to send a letter to the patient saying, dear Mrs. Smith, your mother has decided to enroll with our practice as under the MyMedicare program. This is a courtesy to just let you know that we're very happy to have her on board and look forward to continuing her care. Something that notifies the patient's carers is not something dodgy, and that we have actually actively requested and asked her to sign.
It will take GPs some time though, and I think we need to acknowledge that as well, which is largely
absolutely.
unpaid when you're dealing with relatives and things like that.
You can send another practice staff member up to do that.
Right.
You could send your nurse practitioner. We went down the path of choosing not to get the aged care home involved because we left some forms and they disappeared. So we actively have basically sent our nurses up, and they have had the conversation with the patient. The GP has broached the conversation first by saying, I'm going to send my nurse up tomorrow. She's going to have a quick chat to you and sign you up for what we've just talked about. So the GP has certainly mentioned it and asked for their agreement, and then the nurse has gone up and actually engaged the patient. So there are ways that I completely agree. It is a lot of time going to be involved, particularly for those residents who may not understand and require further explanation.
Yeah, I just want to acknowledge that to all the GPs
Yes.
and nurses on tonight. Now, one other question, which is, what happens when you get a new RACF resident after 1st of August? Can they still be enrolled in MyMedicare?
Yes, and that I believe that will then take on for your next quarter's figures. And that comes back to what I was saying before about how are they going to calculate those new residents that come in during the quarter. So if our numbers are calculated on the 1st of August, for example, and we get new residents on the 15th of August, how is that calculation going to take place? Is it going to be then just calculated the next quarter? That is what my practice would like to know. So that's something that I think, Brendan, you're going to address in your question to the department.
Yeah, absolutely. And the other question that's come on, which I think is a good one, which is there a standard form somewhere for these residents to sign?
Yep. So the form has been updated. There was, in the first instance, when it first came out, it was a very simple form with the front and back. Basic information, patient's Medicare card, their name, their date of birth, and a signature. Now it's been updated to include more demographic information. I believe that's going to be around where we're looking at the aged care home. So it has been expanded. You can put it into your software and just print it out as you require it, or you can just download it. And if you'd like, I am more than happy to send you the form that can be distributed with a copy of the slides. Yeah,
great. That's really helpful advice. Wendy, I'll let you continue on with the presentation.
Thank you, Brendan. All right, so giving a list of the patients to the GP so they know, and give that encouragement to them to have that conversation. And of course, your admin staff, they have a wonderful relationship with your patients, your nurses. They have quite an engaged, involved relationship. So get them on board to have that conversation. They're seeing our patients on a daily basis, so they might be able to explain the process. But remember, if they're not aware of it, they're not going to be able to have that conversation either. So get those lists going. You could send a letter, or you could just get the GP to invite them, encourage the GPs to have the conversation, your nurses to discuss. So this is basically summarizing what we just went through on the previous slide. And as I said, send your nurse up to visit the aged care home to register your patients if that is something you feel is appropriate, and make registration part of your new resident initial care. So get that form filled out when you go and do the CMA or do the admission to your facility. Hang on to it till those 2 services have been performed, and then you can register that patient straight away. It's just going to save us keep going backwards with the process. Okay, we had 30 residents, now where are we? Which are registered, which aren't? So keeping that information easily, so that if Dr. Smith comes out to me and says, is Joan Jones registered with MyMedicare, I can quickly say yes or no by looking at the data. So keeping that information current and then adding to it as new residents appear in our homes, in our under our care. So ladies and gentlemen, in summation, preparing our practice and our staff to both inform and encourage patients to register will ensure we have the best opportunity to continue to provide the high quality care that we already do to our patients in any environment, along with our aged care homes. Using our available data to identify eligible patients and initiating that registration process will ensure we have access to the appropriate funding when it becomes available. And I guess that I'll leave you with that one-liner. If you don't register them, someone else will. So if you need to get these patients on board, because they may not understand what they're doing and be registered with someone else. And yes, they can, they can change their registration, but I think it's valuable for us to get those patients registered. So here are some really great links to some resources if you'd like more information. And of course, the PHN has got some great resources, and they should be your first point of call when it comes to looking for information. So I'm going to stop sharing now and invite Brendan to perhaps read any more questions we may have.
I've got a few comments I might make, which is, what are your top 4 tips for GPs listening tonight in terms of preparing for GP aged care? By the way, everyone, this is unrehearsed, it's live. So what are the 4 top tips that you would give for GPs? Because this is a new thing, right? And and I do feel sorry for GPs, because this is quite a significant change.
Oh, absolutely.
And there's a lot of administration around this, and I think we need to acknowledge that, at least initially.
So I think, yes, I agree. And I think that is why that $130 payment's being made to the practices in recognition of that. All right, top 4 tips. Obviously, the first one is to know what MyMedicare is and what it's going to mean to you. So hopefully tonight has given you a bit of a background, but basically know what it is. So know what you are dealing with and what you need to do. The second one is register your patients. So particularly the aged care home residents, because they are the first incentive to be rolled out. So getting those patients on board, having the conversation, and getting proactive about getting these patients registered would certainly be something I would strongly recommend to ensure that you are going to achieve the outcomes that you hope for your residents, but also for your business. Chronic disease, if we're looking at the top 4 tips, I would certainly be looking at maximising what is available between now and November. So making sure that you are capturing all of your 723s available while they're still available to use is really important, because I think that's something that's going to have a significant impact on us financially for a lot of GPs. So getting that system in place, I guess. And number 4, I guess it would be a case of practice structure. So getting your practice manager and your nurse and everyone working together I have a meeting. Go back to work tomorrow, have a meeting with your practice and say, this is what we need to do. How are we going to do it? That would be my top 4 tips.
Right. I'm going to add to your top tips with my 2 top tips, if I may, which is, you know, our PHN is really committed to supporting GPs. So again, you know, my 5th tip is to say, if any of you are struggling, right, and if you need more information, then reach out to us. Okay, that is really, really important. We're happy to help, right? So Jan might be kind enough to post a link, an email address in the chat, and we're really happy to respond and to really provide that sort of tailored support. All right. Now, the other thing that some of you might be interested in, and I have to do a shameless plug, everyone, which is I chair an aged care assessment aged care advisory group, and that would also be a great way. We're always looking for a few new members. So again, if you do want to join that our aged care advisory group, it meets every couple of months. It's really informative. We get lots of good speakers coming along, and we really want to keep you updated on that on Japaki through our aged care advisory group. So if you're interested, then just, I know it's one more thing, but I think those people who attend that group, you sort of get a bit of inside information about where things are going. And people find that, I think, very helpful. So those are my 2 top tips, and I'm trying to grow the aged care group. So I just had to do a plug for that. Now, look, so I guess the other concern we have is for those non-accredited GPs, right? You know, and I guess we've really got to get some additional information out to them, and so we will take that on board. And I hear the concerns within the questions. Are there any other final comments you want to make to them, Wendy?
No. So did anyone respond to whether they're receiving the aged care access incentive payment? Was anyone willing to put their hand up and say yes or no to that? Because if they are receiving the current model of funding, there may be a workaround for it. So I was just interested to find out whether they're receiving it at the moment, because that again is eligible only through the PIP. So if they are receiving it, there may be a workaround in place already.
So we might take it offline and see what we can do. What do you think? It seems to me that there's going to be a lot of work required between now and August, right?
Yes. So it's been coming for a while, and unfortunately we were not given enough information quickly enough. So as you know, a lot of the information was only released last month. Practices have been actively working towards it. However, I will say that the information was there, has been there for 12 months or since January particularly. But it's about, we need to start thinking, okay, I was very much like, I'm just going to bury my head in sand and hope it goes away, but it hasn't, and it's here. And I think the acknowledgement that it's going to be the only way we're going to receive the funding is really important to say, okay, I have to do this. But also remember that it's the rewards to the residents. So they're going to have, you know, a secure GP that they trust who's going to be committed to coming to see them. So I think that's a really good thing as well. But yeah, I agree 100%. It's going to be a lot of work, particularly if we have a large aged care population.
Yeah. Now, and we've got 159 facilities in our region, so we've got a large number of residents.
Yeah.
So look, how do you know whether a patient has registered with other practices?
So you won't know if they registered with a particular practice, but when you go to register them, it will tell you they are already registered elsewhere. So sometimes the resident, if we're talking about patients or residents or either or either, a patient will not more than likely know, and they can quickly look at their MyMedicare app and tell who they're registered for. But I do believe the answer to that will also come within the linking to the My Health record. There will be some type of information available that will show you they are currently registered elsewhere, without having to go through the process of registering them to then find out that your registration's been refused because the patient had been registered elsewhere.
And I think that's the concern. And so, Jan, we might provide some additional information on that if we could, please. Some residents on respite care become permanent. How do you calculate the incentive payments?
So again, it comes back to the same question we've been asking, which is really difficult. So if they are residents in respite on the 1st of August, they will not be counted. However, if they then become a permanent resident, they will probably not be calculated until the first quarter, the first day of the next quarter. So that is my argument. How are we going to, when we are providing services through that quarter for more than the patients that we started with, are we going to receive funding for them, or is it going to be just first of each quarter, numbers are calculated and that's what you're going to get? Because there is going to be that crossover.
Can I just extend my deep thanks to you, Wendy, for, I know you've had a particularly long day today.
Okay, thank you.
You still look fresh, can I say? But well done for presenting, and also for being so generous with all your answers tonight. We're grateful for that. I dare say we're going to see you again. We'll be running some more webinars on this issue. We know this is an issue of much interest in our region, given that we've got 159 or so aged care facilities. So thank you, Wendy, for that.
You're welcome.
Can I also thank the assessment team on this? I'm simply the front person of this. The person who's done most of the work around this has been, Jan, Yvonne, and Jason behind the scenes, and of course Lauren from our CPD team. So I thank you for that. And Jan, I might hand over to you tonight to run through some slides at the end for some of our special services that I think all of you would be interested in. All right.
I just wanted to actually just talk about some education sessions we're coming up anyway. So we've got, for all you nurses out there, we've been asked to do some networking events. So we've got our second networking event coming up on the 27th of June at the St. George Motorboat Club. So any practice nurses out there that would like to attend, please register. We'd love to see you. The last one was fantastic, and we're hoping to do more in the future. We also have a MyMedicare webinar coming up for RACFs, and GPs will be welcome to attend. It's an overview webinar for RACFs to give them information, and so they understand what MyMedicare is, so they can help support the process also. And on the 11th, and that's on the 4th of July, and on the 11th of July, any GP registrars or GP supervisors out there, we are having a networking event for you on the 11th of July at St. George Motorboat Club. Please let us know if you would like to attend. We will put it out there for you. Okay, that's all from me.
All right. I think that's all tonight, everyone. So can I suggest you, if you're in Melbourne, wrap up well. If you're in Sydney, it's still pretty cold here. So so I wish everyone well. Stay warm, and I'll see you with the next CPD event. Good night, everyone. Take care.
Good night. Thank you, everyone.
Thank you.